All right, can everybody see my screen? Should be on the AAMD website. All right, we are good to go. Well, welcome everybody today. Glad you can make it for our second webinar. We're just going to go over a little bit of business. For those who are new to the AAMD webinars, you do, or at least for these, you do not have to be an AAMD member. These are open to the general public. You do need to create a non-member account, though, so we have a place to track your credits. You can do that by clicking on the Join, Renew, Upgrade button here, create a non-member account, and then you'll be able to have access to these quizzes. You'll also be able to have access to your transcript, which is right here. So for both members and non-members, those are the places you need to know. Take the quiz, which we have on this page. We've got the quiz from yesterday and the quiz for today. We'll also put the handouts for today up here in a little bit. But you'll click here, take the quiz, log in, and that will be added to your transcript, which you can find right here. If you have any questions about the education process, feel free to answer them or ask them in the question box throughout the webinar. I'll be happy to answer them. If you have any questions about AAMD in general, I'll answer those as well. So at this point, I'll turn the time over to our past president, Chris Gaynor, to introduce our speakers.
Thank you very much, Spencer. I appreciate all of that. Guys, I would tell you that if you have any questions after this is over, Spencer's always available. You can contact him through those telephone numbers or through the website. It'll be just fine. But let me welcome you real quick to this Philips-sponsored webinar. And I hope everyone is enjoying their celebration of Medical Dosimetrist Day through all of these webinars. It is an incredible privilege from your board and through your headquarters staff to be able to provide all of this. And we can't certainly do any of it without your participation through the membership in the organization. So hopefully you find it valuable and you can take what we learned today and implement it in your clinic as we try to help people in very critical moments of their lives. So thank you for joining us. Let me introduce our speaker for us, Mr. James Cavanaugh. Graduated from LSU with his master's degree. Went on to complete a 2-year medical dosimetry, or a medical physics residency program, excuse me, at Washington University in St. Louis. He's still currently a faculty instructor at WashU, and he'll be presenting for us today, topic titled A Method to Reduce the Dosimetric Impact of Setup Uncertainties for Multi-Isocenter IMRT Plans. And again, we thank our sponsors, especially Philips today, for helping us put these on. So James, thanks for taking your time, and we appreciate what you're going to say.
Thank you for the introduction. First off, I want to just make sure everyone can see my screen. I think I switched it over. Anyone out there see the screen? Okay, good. All right, so as Chris mentioned, I'm presenting on a method to reduce the dosimetric impact of setup uncertainties for multi-isocenter IMRT plans. We've actually already gone over my background. I wasn't sure if I was going to have to introduce myself, so that was the first slide. A little bit of background about our institution. We have 11 variant Linux, 4 TrueBeams, 4 IX or Trilogies, and 3 21EXs. These are spread out across our main campus, which houses 7 of them, and also 4 satellites. Our record and verify system is Mosaic, and then as this title of this talk and the topic of the week, our planning system, primary planning system, is the Pinnacle Treatment Planning System version 9.0. Now, in reference to this particular subject, 2 radiation oncologists have utilized this methodology, the first being Jeffrey Olson, who actually brought the original paper to our attention and for us to implement. And his was in treating long femur. And the second was Dr. Imran Zuberi. His was with bilateral chest wall. I'll show both those cases today. We have a small team that has been using this in our clinic, 2 physicists, including myself. The second would be Lindsay Olson, and also 2 dosimetrists, Lisa Westfall and Julie Wolfensmeyer, and all 3 of them owe a great deal of gratitude towards making these plans for me to present. So a brief outline. I'll start off with just kind of discussing the rationale for why we even want to use a controlled junction IMRT approach for multi-isocenter treatment plans. Moving from there into a couple of examples. We'll start off with a simple one, the multi-isocenter IMRT femur. This really gets into how you're going to implement it step by step, and the intent for this whole presentation is hopefully by the end you can follow these steps to do something similar within your your clinic. And then getting into a much more complicated case, our bilateral chest wall, and discussing some of those issues. We won't go into a lot of the minute details with the bilateral chest wall, but we will discuss some of the larger issues. So why do we even need to consider a controlled gradient for large targets? Well, typically you have some restrictions, as you all know, as to how large a target you can treat with a single isocenter. For varying Linacs, in your Y direction, you're limited to 40 centimeters for isocentric delivery, and about 32 centimeters in the X direction. Anything beyond this requires more isocenters, and in our clinic at least we have our isocenters separated by a very specified distance, and usually it's in whole units of centimeters. Example of a couple of sites that we treat this way at WashU, femurs, as I discussed, bilateral chest wall, and also pelvis and periortics when you're treating huge lymph node trains, but I won't be using that as an example today. And there's probably many others that you can think of that this might be applicable towards. So what are a couple of approaches for treating these large targets? Well, the first, and this is one we utilized up until recently, is just an uncontrolled junction optimization. Something similar to split field single isocenter optimization, where you have a single prescription, you have a single set of planning objectives, and you have beam arrangements where you have beams that are assigned to each isocenter. There's a small amount of overlap between those beams on the order of about 2 centimeters, and you're going to optimize on all of these beams simultaneously. And that's going to get you your dose distribution. And this, again, this is the uncontrolled junction optimization. This is what we used to do, and this is an example of how we did it. So for the uncontrolled optimization, you had the superior PTV dose that's going to be delivered by those superior fields. You had inferior PTV dose that's going to be delivered by inferior fields, and then you have this junction region, which I just highlighted in red. And that's going to have dose that's delivered from both superior and inferior fields, and that dose, that fluence, is really determined by the optimizer. This is why it's uncontrolled. We're not actually dictating where that dose is going. And so you may have a chance to have some superior dose predominantly delivering to some voxels, and just immediately adjacent to that have dose being delivered to voxels from the inferior beams. So the question is, why is this an issue? And really the answer comes back down to the impact of setup uncertainties. In all clinics, you have set up the patient with a mobilization device. You're going to align to that superior isocenter marks and typically do some sort of imaging. Minor adjustments might be done to those superior beams on imaging, but that imaging has some limitations to the field of view, whether it's cone beam or 2D KV, in which you can't see the inferior aspect of that PTV when aligning the superior beams. So while your superior beams might be on, you may be off a little bit on your inferior part of your target. And typically, once you align, you're going to treat, and you're going to get some dose distribution. At that point, you can, this is just our workflow, shift a known distance to the inferior isocenter. You'll image again, and ideally at that point there are going to be no further adjustments. You've shifted a known distance that you specified in your planning system. Hopefully there's a perfect junction between the two sets of fields. You're going to have a smooth dose transition, and you can deliver the dose exactly as planned, but this never happens. There's going to be adjustments that occur every day. They might be very small, on the order of 1 millimeter. There might be larger, 2, 5 millimeters for those inferior beams. And that's where the concern comes in, because the question becomes, do we shift or do we not shift for those inferior beams on those daily alignments? Well, if we were to apply the shifts to the inferior beams, you may improve your coverage for the inferior aspect of the target. So you can apply the shift, improve your coverage a little bit. You can see that the beams are maybe treating down this region a little bit better. But you could also have the high probability of possibly under or worse overdosing within that junction region, and it could be quite significant. The opposite of that would be not to apply those shifts. It reduces the risk if you don't apply the shifts of that under or overdose in that junction region. However, you also deteriorate the coverage to the inferior aspect of the PTV. And so neither of these situations are ideal. You don't want to have this possibly really large hotspot due to these setup uncertainties, but you also want to make sure you're covering as much as possible. This leads into this second method, and this one we'll be discussing today, the controlled junction optimization. At least that's what I'll be referring to it today. The controlled junction optimization uses a controlled stepped dose gradient in the junction region. And you do this by creating a roughly 6 centimeter junction. Superior beams will be delivered first, and they're going to deliver the full dose to that superior PTV. And then you can kind of see, I did this cartoon, so you can see grayscale where it gets a little bit lighter as you're moving towards that inferior PTV. It just shows that you can control gradually the dose fall off moving towards it. And these are obviously older techniques that have been around for many years. But in terms of IMRT plans, this is going to help us minimize our setup uncertainty. And this technique actually was shown for long field femurs by a group out of MD Anderson, I believe, Zhang et al., a paper they published in 2007. Then once you do the inferior fields, the beams are going to deliver the remaining dose to that inferior part of the PTV and fill in that junction region. So Zhang et al. Actually described 2 techniques to achieve this gradient. They had a technique that used superior static beams, and then the second set of beams were IMRT. The first set of beams were 3D. They had the way you basically achieve that inferior gradient in the junction region was to slowly close. Sorry, it is PMH. I apologize. Slowly close that inferior jaw to control the gradient, and that. Then the IMRT was delivered from the inferior beams to fill in that junction region. What I'll be talking about specifically today is IMRT, where the superior or the first set of beams is delivered by IMRT, and you could get that optimization gradient by using optimization objectives across the junction region. Within their paper they published, they noted that they were able to maintain plus or minus 5% dose heterogeneity in the junction, and then less than 5% dosimetric change due to 3 millimeter setup uncertainty. So a couple of cases that, again, I'll be describing. Femur, that's a simple case. You note here, though, that it's going from about the hip down to the knee. It's about 52 centimeters long. It's a simple case simply because there's very few organs at risk. There's minimal exit dose from each set of beams into the other set of beams. And it's just a much more straightforward optimization. You can focus on that junction region controlling that gradient. In terms of the bilateral chest wall, there's significantly more OARs to worry about. And since it's bilateral, we don't have a sup-inf difference between our fields. You actually have a significant amount of exit dose, which can make it much more difficult to maintain those hot and cold spots. Okay, so now moving into discussing the multi-isocenter technique specifically for the femur. In terms of immobilization and simulation, mobilization is critical for multi-isocenter IMRT plans, even more so than compared to regular IMRT treatments. And the largest part of this is just because we're doubling essentially the time that the patient stays on the table. There's twice as many fields, there's twice as much imaging, we're going in and doing these set shifts, and because they're on the table much longer, this increases the chance that the patient could move between the isocenter treatments or during the treatments, which again, not only is it set up uncertainties, but patient moving could also cause these hot spots or cold spots to occur. So mobilization during the setup process is really important. And we also have to consider not just moving in terms of shifting, but also some rotations as well. So we have to pay particular attention. The patient that we set up for our first example utilized alpha cradle around the hip, knee, and also the ankle. All joints were immobilized, since that way we could help minimize that motion, both shifting and rotation. You can see that the ipsilateral, in this image on the right, ipsilateral femur was straightened so that you're able to have just a straight sup-inf shift. You don't have to worry about an anterior-posterior shift between isocenters or a lateral shift. And the contralateral leg was also separated as much as possible so we can have as many beam angles to utilize during our treatment. For the femur simulation, typically an isocenter was placed at time of sim that was centrally located. This was done just due to the fact that we weren't entirely sure if we needed to have multi-isocenters, and that could be the case in many clinics. From that set preview point, we actually then specified both an inferior, or superior, and inferior isocenters to be used for planning. The central isocenter was the one that was marked, and you can also notice that the sagittal along the femur was marked as well to minimize rotation. So just a general flow going from the mobilization into the planning side, just a really brief outline of what I'm going to talk about. So first of all, you're going to plan the dose to the superior PTV, delivering full dose to the superior part of the target and controlling the gradient in the junction region. At that point, you can lock the superior dose distribution, keeping it in place, and plan the dose to the inferior PTV, which will deliver the remaining dose, which is pretty much the full dose to the inferior PTV, and filling in the remaining dose in the junction region. So you can see here the example of, in this case, why we were utilizing the multi-center approach. Again, you can note that it's from all the way up from the hip, all the way down to the knee, and going pretty much across the entire part of the thigh, and then once you get down closer to the knee, it was mostly just around the implant and also the scar along the surface. And there's a better example of the length that we're looking at. So just step-by-step, first creating the isocenters. As I mentioned before, there's an integer shift from the preview. We keep it integer just because it's easier to remember it, and you're going to minimize possible errors done at the time of treatment. You have the same lateral and ant-post coordinates as the preview. So note here, preview is zeroed out, and you can see these differences are due just to my measuring inaccuracy, but it's about 6 centimeters to the superior isocenter and about 13 centimeters to the inferior isocenter, as noted here. One thing to note is you want to maintain less than or equal to 18 centimeters from wherever your isocenter is to the closest border of the PTV, just so you can make sure you can contain it within the either superior or inferior fields. And also, when you're planning this, you conversely will want to minimize the separation between your isocenters to minimize the amount of divergence from your beams into the adjacent beams. So in terms of femur contour delineation, this is the big part. This is a time-consuming portion of this planning process because we really have to set up all of these junction regions. So the first step is to just create your primary junction region. That's shown in this orange here on the right. And you do that by copying the PTV, and we renamed ours PTV junk. And we delineated a 6 centimeter long region of the PTV junk. So if you took the copy of the PTV and we determined we wanted it to be 6 centimeters long, you want that to be located between the isocenters, your superior and inferior isocenter. And ideally, it's going to be in somewhat of a cylindrical region of the target so that it minimizes the complexity of the fluid that's needed to maintain or achieve your coverage. So you're going to determine both your superior and inferior border that can be specified by both of these points, and then delete the rest of the slices that aren't delineated between those two borders. That's an example of the rough size of that junction region. And again, a minimum of 6 centimeters. The next step is to create your junction subregions. These are the op structures that are going to be used to really control the dose gradient. And in terms of a 6 centimeter long junction region, you're going to want it to be at least a minimum of 1.2 centimeter thick subregions. We specified ours just kind of straightforward, junction 100, 80, 60, 40, 20, and you can see as I'm filling in here, the red represents the 80, the initial yellow was the 100, orange being 60, dark green being 40, and purple being 20. You also need to clearly delineate the superior PTV op structure. Again, this is an optimization structure. That's the PTV volume that's superior to this junction region, and this is going to get the full dose during this optimization of those superior beams. And as a note, and I'll discuss this in a little more detail later, it really shouldn't include this junction 100 region. Because if it does, you're going to have issues controlling the hot spots within that region. For conformality, you can also add additional rings around your superior PTV. We, in this case, added 2 rings. One was a 5 millimeter expansion and then an additional 2 centimeter expansion beyond that. Note that it was included not just around the superior PTV, but also that junction 100 region. That junction 100 region is going to be getting prescription dose during the superior optimization, we just wanted to have that in place so we can control the maximum dose of that structure. I'll discuss that in a second. In this case, we found that we didn't typically need too much of the rings. We were able to control the dose conformality pretty well, but in complex cases, it does become very important. In terms of beam placement for superior beams, we are defining ours manually so that the field size is not controlled by the optimizer. One thing to note is you want to extend the inferior border about 1 centimeter beyond inferior to the junction 20 so that you can really make sure you're getting access to the full junction region when you're optimizing. All of these are obviously attached to the superior isocenter. We had a particular naming convention. You can do whatever you like within your clinic. This kind of followed what we had, where we had our site and beam identifier, our angle description, our beam angle, and then we specified what set of beams were upper, and then the anatomical site. For the superior beams for this patient, we utilized 7 fields, pretty uniformly spaced, obviously not coming from the left side of the patient just because we wanted to minimize dose coming through that contralateral leg. Beam placement for inferior beams follows a very similar path. Again, we're not letting the optimizer define the field size. We're extending it 1 centimeter superior to that junction 100 volume. And again, it's very similar naming convention. And in this case, we utilize, I believe there's 6 beams here, less just because it was a little bit less complex target in the inferior portion of the PTV. So in terms of how you want to set this up, you're really going to need, because we're going to optimize these separately, you're going to need to use 2 prescriptions. And there's 2 reasons for this. One is that we're going to optimize the superior beams first, and Pinnacle is going to require all beams that are attached to the prescription, any prescription, have to be optimized on at the same time. And so since these are going to be optimized separately, we needed 2 prescriptions on the planning side. And then we will typically treat many of our patients on our true beams, and since both of these would have significant couch differences, and this is not really impactful on the planning side, but just as a side note, both of these would have significant couch differences in terms of where the couch is while we're treating. You're going to need to have 2 prescriptions in Mosaic as well. So some of the optimization structures for the superior PTV optimization, objectives I should say. You will have pretty much standard optimized max min for the superior PTV op because we want full dose to go to that during the superior optimization step. And I weighted these pretty heavy because we wanted to make sure we were achieving this because obviously we weren't going to make up any of that with the inferior beams. Junction 100, the goal is to achieve the prescription in that junction 100 region, but we really want to minimize that hot spot. And that's because you're still going to get some dose from the inferior beams within that junction 100. And this is actually one of the errors that we found, or one of the issues we found as we progressed through this patient and caused us having to go back and optimize several times and come up with a solution. So the goal with that junction 100, you can see those objectives down here, is to really have a max dose that's just slightly above the prescription and weight it actually pretty heavy and keep that min dose. We have found that you can put it right at prescription. Because if you note, we could still get dose delivered here from the inferior beams, but if we were to already achieve our prescription or higher, you're going to get some really big hot spots just in the planning process. And then for the rest of the structures, they follow a pretty steady pattern. And for instance, as an example, the junction 80 would have a max dose right around the prescription, and a min dose about 80% of the prescription, thus why it's called junction 80. And then we created a max EUD that was about halfway between those 2 data points. Very low weight for all of these, and it followed the same pattern for each one of these substructures. Some other goals for those ring structures, which we did use, the 5 millimeter expansion had a Dmax of prescription and a max EUD of about 95% just to get it to start falling off. And then the 2 centimeter expansion beyond that had a Dmax of 90% of the prescription and a max EUD of about 65, and they were moderately weighted at that point. Obviously this can be planner preference in terms of rings, and I think everyone has their own approach. So in terms of how to evaluate the superior PTV dose evaluation, when you look at the subvolumes, you want to see a couple of things. First of all, you want to note that for each of these subvolumes, and Purple is 20, as you can see here. Green's 40, 60, 80, and then you have the 100, and then the superior PTV in the far right. You want it to be fairly linear between what you had as your minimum and what you had as your maximum objective. You don't want it to be a step. Then that's why we made those two values pretty far apart, about 20% of the prescription, because we want it to be a pretty gradual fall off and not a step wedge fall off approach. Also note that your junction 100, because we really were pushing on that Dmax, you won't achieve that full prescription in there. You're going to be a little bit close. In this case, we got 50%, but you can tell that it is still a target structure, and so we still want to try to minimize that hot spot, but maintain that similar structure that we'd see for a PTV. And here's an example of the dose evaluation. These 2 points here are the superior and, sorry, these are not the superior inferior isocenter. They're just extended 2 centimeters beyond the junction region, so we can look at a dose profile across that junction region. And this is the dose profile on the left. Really close to the junction, you're pretty much sitting right at the prescription, and you can see a gradual dose fall off all the way until you get outside of the junction region. And I just had a question that says, please touch upon what EUD is for non-pinnacle users. So what we were utilizing the EUD for was not necessarily its full purpose. We were using it for a mean dose objective. So essentially, and I won't go into detail, but you have different parameters you can adjust for an EUD, and if you set them a certain way, with your alpha value being 1, you can control essentially the mean dose to that structure. So that was the reason why we're adding these EUDs. So basically a max EUD in this case is saying the max mean dose that we wanted to this particular junction 80 was about 90% of the prescription. Let's see where I left off here. So once you have achieved the dose gradient you like and you've got the coverage that you want, and that's important, you really need to have that coverage, that superior PTV. Once you achieve that, you then go through a couple of steps. First, copy the trial, and then change in the IMRT parameters. You're going to change the superior beams from DMPO to static, because we're not going to optimize on these superior beams. They're set now. And in addition to not even optimize on them, you're going to lock all of those beam weights, because what you need is to have that dose distribution in place so that the inferior beams know how to fill in the dose in that junction region. And then in terms of, and I had a question, which direction is the leaf travel relative to the junction? It's not exactly perpendicular to the junction because the femur is a little bit slanted at an angle, but essentially the leaves are moving from left to right. So these are 5 millimeter leaves. That's why we wanted the targets, the width, to be over a centimeter, but not exactly at a centimeter. So inferior PTV optimization objectives. The standard PTV objective is going to be Dmax, 104 prescription, Dmin 102. Note here that you're optimizing for the inferior PTV. You're optimizing on the full PTV. You're not optimizing on an optimization structure. And that, because of that, you don't need to optimize on any of the junction structures either, because it's going to then know to fill in the remaining dose. The superior PTV, 5 millimeters, Dmax about 101%, Rx, max UD 90%. These are very similar to, I should say superior, but these should actually indicate inferior. Very similar to what the superior ones were in terms of the ring goals. If you wanted to look at the actual inferior PTV dose evaluation, you could turn off that superior dose within the prescription and just look at how the inferior dose was achieved. You're going to see pretty much the same gradient, but just in reverse. So going from superior to inferior, left to right, you're going to see a very low dose, and it's going to ramp up across that junction region until it reaches just beyond that junction region. You should have also some very similar DVH values, but again, in reverse. So your junction 100, which was close to, but kind of gone a little bit cold, but very close to prescription the whole way, received very minimal dose, less than 5 gray. Whereas as you're moving up junction 80, junction 60, junction 40, 20, it's the opposite order from what you saw before. One thing to note is your inferior PTV. We didn't optimize on this, but just to get an idea of what the dose was to that inferior structure. It looks a little bit cold here, but that's simply because the superior dose was already present, and so it wasn't, the inferior beams did not deliver full prescription because it was just filling in for what was left over from the superior optimization. Minor variations across, this is the full PTV dose evaluation. Again, you've already evaluated the superior and inferior dose of the actual PTVs, but what you should be looking for when you're looking across the junction region is that you're achieving, one, achieving the prescription across there, but two, minimizing those hot spots. So you should see some minor variation. And on this example, the y-axis right on the bottom, that's prescription, and up here is about 8%. 108% of prescriptions. So you're seeing some variation, but it's actually very minimal variation across that junction region. One thing to note is this hot spot right here corresponds to a point that's sitting right about that 100 or 80 junction. And the question is, well, why is that hot spot located there? Well, typically you're actually going to see it either in the junction 100 or junction 80. And the reason for that is the superior beams are going to try to deliver full RX to junction 80 or 80% of the RX or even higher to junction 80, but divergence from those inferior beams while they're trying to deliver dose to maybe the junction 60 or the junction 80 are still going to have exit dose passing into that superior PTV. And so if you didn't really push on this junction 100 and even to some extent the junction 80, you're going to get your hot spots located right there. And that's why in this case, and this is the last slide for the femur portion at least, and the planning side, one thing to consider is when you're defining your superior PTV op structure, instead of including that junction 100, it's a better idea to exclude it so that way you can really push on this to minimize the dose, the hotspot dose, to just slightly above the prescription. Someone asked a question how to get this profile of dose versus distance. You can draw, and I don't have a slide to do a step-by-step through this, but essentially you can draw a line really anywhere. And typically what comes up first is, instead of dose, it's actually Hounsfield units, but there's a drop-down menu that you can select a different data set. So instead of selecting the CT data set, you can select the dose data set, and that's going to get you this dose versus distance as opposed to Hounsfield versus distance. And someone was asking for, I mean, there's a lot of uncertainty in here because there's obviously this high density. We did override where the artifact was, and then we had the density for the actual structure set to as close as we could get what the density was for that metal. So here's an example of where the hotspot is. If you do optimize, you really push on that junction 100, or if you don't really push on that junction 100. On the left, you can see that the red located here is 110% of prescription, blue is prescription, and purple is 95 prescription. You can see that we have a little bit of that 110. It's located in, actually in this case, in the junction 80 region, not in the junction 100 region, because you really, during the optimization process, minimize that dose from the superior beams here. On the flip side, if you don't really push on that junction 100 region, you let it go to maybe 105 during the superior beam optimization, you can, because of that beam divergence, you can really get a hot spot. And so just as a tip, try to push during the optimization. Oh, and I did not mention this, and that's a good point. Prescription in this case is 45 gray, and they were looking for 95% coverage, 95 and 95. So just now finally moving into a little bit of the evaluation side, looking at the impact of setup uncertainties. So in this plan, the physician wanted to get a little bit of an idea of what those setup uncertainties were, and we actually wanted to investigate, the impact of this technique versus our typical technique. And so what we did was we optimized a second plan so that it had the same coverage and the same dose in the rings, same fall-off, utilizing both the controlled gradient, which is these two columns here, and the uncontrolled gradient portion. And then we shifted the inferior isocenter either towards the superior isocenter to replicate a 2 millimeter or a 5 millimeter setup uncertainty, or away from, again, 2 millimeters or 5 millimeters, to get an idea. And so if you look at no shift, in this case, and these are a little bit rudimentary metrics, but in red that shows the maximum dose, blue is the minimum dose for that type of plan. And then d-means are located or also monitored to make sure that you have the same mean dose across all. So in this case, you can see with no shift, we had a max of 51.2, which is very similar to the uncontrolled. Min dose is very similar. And actually, in all cases, the mean dose for that full PTV varied by less than a gray. It really was not impacted, which you wouldn't expect it to be. However, when you're looking at the 2 millimeter shift closer together, the hot spot for the controlled barely went up, a little over half a gray, but the hot spot for the uncontrolled went up by over 4 gray. For 5 millimeters, you did see a little bit of increase in the hot spot for the controlled, but it was 8 gray less than the increase for the hot spot for the uncontrolled. Looking at when you're shifting away, you're concerned more about the cold spots in those junction region within your PTV. Again, for the controlled, you had a 1 gray cold spot change for 2 millimeters and 2 gray for 5 millimeters, and it was significantly more for the uncontrolled. And I'm going to show some images of where those actually showed up. So we have on the left here the controlled gradient technique. On the right, this is the standard optimization of the uncontrolled technique. And this represents the 2 millimeters shifted closer together. You're seeing a little bit of the hot spot within that junction region, which is where you expect it to be for the controlled technique. And again, just so you have your isos lines, 110% in red, prescription is blue, and 95 prescription is in pink. In the uncontrolled technique, the hotspot actually existed inferior to the junction. And this actually makes sense because you're getting pretty much full fluence from the inferior beams down here, but you're also getting that divergence from the superior beams. And as you're shifting into the superior beams, that's likely where you're going to see the hotspot increase. In terms of the DVH, they actually had very similar DVHs where you see a little bit of the change. You can't really replicate it, but it's really a very small volume increase in terms of by about 4 gray for the uncontrolled technique. This is even extended further for the 5 millimeter shift closer together. Now in the junction region, you see an extensive amount of volume increasing for the 110% dose, and that's again to be expected. That's why we're controlling it. However, and it's very similar actually for the standard uncontrolled technique, but your hot spot, and you can see a little bit how this is impacted on the DVH. In the solid line here for the DVH, that's the controlled technique, that's controlled gradient. You saw an increase in overall volume for about 110%, but your hot spot was significantly lower for the small voxels, the small hotspots. So for the uncontrolled, 63 versus 55. Going the opposite direction, you had a little bit of coverage that you lost within the junction. You're typically getting 95%. There's a couple holes there where it's dipping below 95%, but you're definitely losing that coverage down below here for the uncontrolled technique. Again, you really can see that for 2 millimeter shift apart is about the same DVHs because the volumes are so large. But you're really getting cold, and I think where you see it furthest, and again 5 millimeters, is you're losing some of the coverage throughout the junction region to a larger volume, but you're still maintaining that minimum dose. So it's not getting very cold, it's just getting slightly cold for a larger volume, as opposed to the uncontrolled technique where it's getting very cold for some of the volume. And just as an example, I want to show this is 95%. This is with a 5 millimeter uncertainty. The control technique is a little bit colder for a larger volume. So at 95% of the prescription, you're getting 92% coverage versus the uncontrolled technique, which is 95% coverage, but you're still getting much, much colder for a small portion. Okay, so that covers kind of the basic setup for femurs as a primary example of how to kind of step through the planning process. But now moving into a much more complex case, the bilateral chest wall. So this was a 43-year-old female with inflammatory right breast cancer, stage 4, grade 2. Actually, and I wanted to show, this is the least graphic picture. The chest wall, the cancer is actually extending through the skin, both on the anterior side and posterior on the back. Prescription was 50/40 and 28 fractions, and we used 6x or 6 MV fields with 1 centimeter bolus. It's quite extensive disease. You can see the PTV here. It took a couple of different axial slices, extending all the way posterior, almost to the cord on some slices, almost to the spine, and wrapping around and then ending up on the left side about midway down the side of her chest. And then sup inf was quite extensive too, extending almost all the way down into the abdomen. So in this case, we're not as concerned about sup inf shifts as much as lateral shifts. So you have multi-isocenters, so we can get full coverage to this very large target. And so in this case, we're creating right and left isocenters. Again, integer shift between the two, and these isocenters were placed close to the chest wall in order to help make beams as tangential as possible so we can minimize the dose to the lung. So someone asked the question, shouldn't the optimizer recognize hot, cold spots in the junction region of prescription 1 and account for that during optimization of the second prescription? It does, but the point I was trying to make before was in that junction 100 region where you're already at, let's say, 104%, because it still has the beam divergence where the beam's passing through junction 60, junction 80, and then into junction 100. It's trying to deliver fluents to junction 60 and junction 80, but it can't drop from some fluents to those and then off to nothing going into junction 100. So it's still going to have some exit dose that's going to contribute dose, and that's the real concern. So to minimize those hot spots, you really kind of push on that junction 100 to allow it to have some leeway. But back in terms of the chest wall, isocenter locations, like I said, are maintained as close to chest wall as possible for beam to make sure that we have tangential beams. Our structures, we actually use in our clinic, use something called PTV skin flash. It's an optimization structure that's used to ensure X-ray fluence in the traditional flash region, which is for most patients it typically is plus or minus 5 millimeters from the skin. In this case, since the disease extended right to the skin, it was the flash region was extended 1 centimeter beyond the external. And then we also treated with 1 centimeter bolus all through that region. And the whole point of the PTV skin flash is to get fluents moving in there so that you can actually, if the patient were to, as she was breathing, you were not going to move in and out of the X-ray fluents. So chest wall contour delineation, in a very similar form, you're going to, again, define your junction region. Again, copy the PTV, rename your PTV junk. In this case, we actually decided to place this junction region on the anterior to the sternum, and that would allow us to at least use the sternum during our setups. So we have a clear point of reference. And as note, you have, and you might note that there's only 4 junctions here, and I will come back to that. And we did have a small junction 100, and we found out that because you're having significant exit dose, because all the beams are in the same plane, it was much more useful to have a very large junction 100. So I just wanted to show these 4 as the 20, 40, 60, and 80. You also have to subdivide, if you're going to use this PTV skin flash, subdivide that junction as well. And remember that this is going to run the entire length of the region where there's going to be some issues if you have setup uncertainty. So in this case, it's running the entire length of the sternum, and you can see they're quite large subregions. Again, we were utilizing rings for our conformality purposes. There's a 1 centimeter expansion for, and I said superior, and this should be right. Actually, it says right PTV ring, 1 centimeter, and right PTV ring, 2 centimeters. And in addition to that, we have something that we call bridge. It's in just a larger optimization ring that you could, if you chose, subdivide it based on OAR. In this case, it was 5 centimeter expansion beyond that 2 centimeter ring. The skin flash is just a 1 centimeter skin expansion it's 1 centimeter PTV expansion through the skin assigned during optimization to a density of 1. If there's no bolus that's used, then when you evaluate the plan, you turn off that density override. In this case, bolus was used, so the density override of 1 to that 1 centimeter expansion was utilized the whole time. In terms of beam placement, for right isocenter beams, we place these manually in terms of field size. We set our field size and also in terms of angles. One thing to note is we wanted everything was attached to the right isocenter, and beam angles were similar to standard chest wall, attempting to make it tangential as possible in order to minimize dose to the lung, dose to the heart, and in this case it went so far inferior dose to the liver. And we did actually utilize, one thing to note, is utilize a right lateral for the anterior chest wall. And that was something we didn't utilize here, but in retrospect it would have been quite helpful. And that will be, I'll talk about that right at the end. Optimization goals for the right PTV beam optimization. RX coverage, 95% prescription covers 95% of the target. This is obviously much more complicated than the femur due to all the extra normal structures. And in terms of our normal structure optimization goals, for the ipsilateral lung, V20 less than 30, V5 less than 100, D mean less than 22, contralateral lung, V20 less than 8, heart, V25 less than 25%, D mean less than 20. Now, to note, these are actually our unilateral chest wall objectives. So during this planning process, we actually pushed on these a little bit harder than what we normally would because we knew that there was going to be some exit dose coming from the opposite side. And that exit dose, that dose, like for instance, the right lung would increase by about 1 to 3 gray. So looking at the right PTV dose evaluation, there's a couple things to note here. First of all, there's a cold spot distal to the sternum. You can see that right here. So prescription is in green, 95% is in blue, and there's a little bit of a hot spot in red. And the reason for this is if, I don't have my beam angles turned on, but for these tangential beams that were passing through this junction region first, they were largely controlled by the fact that the junction here was trying to make a max dose of 20% of the prescription and then 40%. So you really couldn't get the fluence coming from really anything medial to get down to this deeper part of the PTV on the right side. And this is the reason why that right lateral, which we typically don't use too much of because we don't want the dose to spill out into the left side of breast, but in this case, since it's bilateral, it's something that we can deal with later. But this is something that that right lateral really could have helped us utilize by delivering a little bit more dose into this region. And this is an issue we saw later on and caused us some issues with hot spots. Evaluate dose to lungs. Again, minimize low dose to the contralateral lung and evaluate dose to the heart as you would for a normal unilateral breast, but really trying to note that you're trying to push it as far as possible because you're going to get increase in dose. Here's some of the DVHs for the right optimization. Again, you have 20, 40, 60, 80 in terms of your junction structures. They're following the similar pattern that you would normally see. And as I pointed out for our target, and this is the right opt target, it was a little bit cold in that anterior portion. On the right here, you see some of the normal structure DVHs just as an example. I won't cover this too much because we're going to evaluate the full DVHs later on when we look at the final. And then left isocenter beams are again placed so that you can include that junction region while still getting the full coverage to the full left PTV. And then you're going to have everything attached to the left isocenter. Similar to the standard chest wall, this is a very similar setup that you would have for the right isocenter. You can see that you are indeed including multiple beams passing through this junction region. That's important because if you only have 1 or 2, it's going to be very difficult to control that dose to that region without having hot spots coming through the rest of the breast tissue. Again, once you have optimized on your superior beams, you're going to lock all those dose distributions, copy the trial, and then change those superior beams, I say superior, change those right beams from DMPO to none. And then you're going to optimize on the full PTV again, getting that dose distribution. Now, this is dose evaluation for the entire target. Note that this red line here is 110%, and it's actually really quite hot. That was something that was intended in this case because of the target extending through the skin, and that was the very high grade tissue, and so the physician actually, when we showed this to him, we thought he would be concerned about that, and he was actually in favor of having it hotter right along that skin line. So the hot spot is anterior. Hot spot is on the anterior chest wall, and the reason why it's so large over here, though, is because we did not have that junction 100 that extended into that right breast far enough. It has a small portion here, but what we needed to have done is to have extended it about 8 to 10 centimeters over and really push to try to minimize the hot spots from those right beams, because what ended up happening is we're getting about 103 to 100% of the prescription just from the right optimization into this region, and then when you had all of that exit dose coming in from the left beams, it really brought that hot spot quite high. In addition, like as I mentioned before, we could have used the right lateral to get some more dose into this anterior portion of the PTV, because that was really restricted from just the right optimization. And you can see here we actually got, I think, 93.5% at 95% prescription, but it was a plan that was quite hot by intention. And then one of the last slides, a couple of last slides, some hints and tips for planning the bilateral chest wall. Impact of the exit dose. Exit dose is really huge. Since this is not a femur, we have to consider it. We must anticipate dose increase just from the right PTV normal structures. And so it's critical to really minimize the dose of the normal structures from the right side of target. As I mentioned before, included junction 100 is extended laterally. I said 5 to 6 in this slide, and you can see an example of that here, extending 5 to 6. It does two things for you, actually. It will minimize the dose for the hot spot in this region, but also would help you in pushing that prescription dose further in a little bit closer to the chest wall. And the other thing that I think would be very helpful, and we looked at this briefly, is instead of having 1.5 centimeter wide junction subregions, make those a little bit broader, and that allows the gradient to be a little bit more gradual, and you can utilize that in allowing you to get this dose back down into the PTV. And here you can see what was just the right chest wall where it was a little bit cold, and then the dose that was filled in from the left-sided beams. So that is all I have to present, and I'll try to get as many questions that I missed. I know there was a couple that were coming in that I just wasn't able to answer as I was presenting. Thank you for your time.
All right, let me just jump in real quick. Thank you, everyone, for attending. You do have to complete the post-webinar quiz in order to receive credit. The links on the homepage will take you back to the National Medical Dosimetry Day page. The quiz has been up since this morning. Take a few minutes, complete it now. It's also available now through September 30th. So those that want to stay around for the question and answer are free to do so.